Right. So yeah. So the iron, the WHO data show that about 28% of the women in the young age, childbearing period, are iron deficient before pregnancy, before they become pregnant already, and that's in the developing world. In the developing world is 50%. In the developed world, the West is around 28. So this is the commonest thing. Keep simple things. Why I am talking about this? Because when young ladies come to the A&E with iron deficiency anemia, well tolerated, happened over a year because of a heavy period, whatever, they transfuse them before they think about what is causing the anemia. And what happens? They develop antibodies. Yeah, so this is the message number one. This is very important. Simple things can happen. Why do they rush for transfusion? Because they just believe that the transfusion is the answer for the anemia. The transfusion is not the answer for the anemia. And the young patients tolerate low hemoglobin, and in fact because the body is used to it, it develops over months, and you find them totally asymptomatic. You find them pale. When I was doing pediatric hematology, I was asked to go and see a child 4 years old with hemoglobin of 40. He was running around in he didn't feel he's done well. The GP just checked the blood count and found 40. They wanted to transfuse him. I said, well, you don't need transfuse. It's been like this for 6 months. Why do you transfuse him? Just give him iron. And the iron has got a big discussion about the oral iron, because what's the problem of the oral iron. And we're going to talk about that in a minute. So the definition of anemia, again, I'm not going to go into full details about definition of anemia. You're all aware of it, but you are aware of the physiological anemia of pregnancy. Now, simple thing, again, this definition, according to the WHO, is with 11 grams per deciliter. We use gram per liter in here, so it is 110. Why is the hemoglobin lower in pregnant ladies while the higher blood volume? Do you know this? It's simple as well. The red cells are actually more in pregnant ladies because they need more oxygen and more. But the blood increases, the red cells increase by 45%, but the plasma increased by 55%. So it's rather diluted. Okay, that's simple as this. Now, severe anemia is specifically defined as hemoglobin of less than 70 grams per liter. And again, I am against definitions because everybody is different. If the patient's got sickle cell, for instance, this is the normal hemoglobin. So it is important to individualize medicine. Medicine is not protocolized. Yes, protocols help us, but we write the protocols to try and provide a better service. I will allow enough time to questions, and I will, as I said, I'm going to keep it simple. So the commonest cause of anemia in pregnancy is iron deficiency, and not sickle cell and not thalassemia. And by the way, I always try and when I teach hematology, I tell the hematology students and the hematology doctors that anemia is not the problem in sickle cell and thalassemia. The problem in sickle cell is thrombosis, VTE, as we mentioned before. Yeah, and the problem in thalassemia is iron overload. That is the real problem. Yeah. So iron deficiency anemia is common because of the reasons we mentioned. We need more iron during pregnancy, and young ladies are already iron deficient or low in iron stores before they become pregnant. Imagine when they become pregnant and then they get pregnant again and they get pregnant again. They run out of. They will be 100% after in the third pregnancy iron deficient. And the problem is how to replace the iron, which we'll talk a little bit more later on. Vitamin B12 deficiency is not common in this age group, but there is a problem in the diagnostic tool. I mean, I think Dr. David Semcox is doing a project in Liverpool regarding not to use serum B12, is using serum holocopalamin, some other tests, because there is discrepancy between the B12 in the serum and the B12 in the cells. We cannot measure the B12 inside the cells. It's difficult because you cannot get it from inside the cells. And not every B12 in the serum can actually get in cells. And sometimes you have diluted B12 in the serum. It's diluted, it's low concentrated, but the normal is now normal inside the cells. The plasma is normal or reduced while the cells are normal. So there's a bit of discrepancy. I'm going to come to that in a minute. I'll show you just simple diagrams. Folate deficiency is also, as you know, is common because of the increased requirement by pregnant ladies. Now, yeah, I'll just move quickly through this now. Technically speaking, What's that?
I'm very impressed.
That's busy. That's very known thingy in here. Yeah. Okay. So basically, as I mentioned, serum B12. The all right. Okay, we'll get this right now. Does it work? Okay. Hemodilution, fetal transfer, whatever the cause. What I wanted to comment on this is that this is what I was saying here. There are 3 different tests for iron deficiency, and by the way, just keep it simple. You only in the NHS you only find serum B12. Keep in mind that that does not always reflect B12 deficiency. You'll find in the majority of pregnant women B12 is in the low side or even reduced. It doesn't mean that they are B12 deficient. However, until we improve the laboratory laboratory tests and get methylmalonic acid, which is difficult, or holocobalamin, which they call it in some laboratories active B12. So it gives you an indication of what proportion of B12 can get inside the cells. And I may have a diagram for that later on. Right. Okay, we'll just move on to the next, just for the sake of time. So the advice is dietary modification, iron supplementation, and intravenous iron. I think many places use intravenous iron. I'm going to comment now on the dietary iron, not on dietary iron, on the oral iron. What is the problem with oral iron? Practically, let's keep it simple. They don't take it. Why don't they? Yeah, absolutely. Why don't they take it? Has anybody tried iron? Yeah, I'm going to tell you the answer from physiology. How much iron? I'm going to get to the probably the website of the NHS. How much iron do we need in our daily? Read that. It's physiology. We need 8 milligrams, or in women in the childbearing period, 14.8 milligrams. How much iron in the tablet that you prescribe for? Not me, you. Or you prescribe. What do you prescribe? Ferrous sulfate 200 milligrams, and tell them how many times you take it. What's the BNF say? The BNF says 3 times a day, and now I've reduced it now to twice. Is it right? Once a day now. 3 years ago, 5 years ago, it was 3 times a day. And we keep telling them that's wrong. And this research is showing that is wrong. Why is that wrong? Because you probably mentioned about hemochromatosis. We have a gene in our body, which is the hemochromatosis prevention gene, HFE gene, prevents the absorption of excess iron. It will stay in the bowel, causes constipation. They won't take it again. 3 days maximum, most of people probably. So we need 14.8 milligrams maximum. And you know what? Imagine who does that. Not the prescription, Holland and Barrett. Holland and Barrett, 14 milligrams with vitamin C, guys. Vitamin C. Vitamin C is important for absorption of iron. I have seen patients referred with hemochromatosis, and they actually don't have hemochromatosis. They've been taking 2 grams of vitamin C, not pregnant ladies, a gentleman. But he's saying, I have a lot of iron in my body, and somebody told me I have hemochromatosis. When I checked, he didn't have hemochromatosis, but he's taking a lot of vitamin C. So he's absorbing all of his iron. So this is a very practical point. Practical, simple and practical. Don't give them prescription iron. I'm responsible. Don't give them. It's too much. They won't take it. You said they won't take it. So this is, by the way, I don't have any shares in Holland and Barrett. And Boots have the same product, so you can buy Boots anyway. So okay, iron and vitamin C in a tablet, 1 tablet a day. It says in here 1 a day. 1 a day. Okay, that's the answer for oral iron. That prevention for any young ladies before they become pregnant and after they become pregnant and between pregnancy. This is a practical, simple advice. Okay. Now, try and get back again now. No, the brand is not important. I'll just have to drag this away. Right. So this is the practical advice in here is regarding the oral iron, and it's explained why we cannot absorb this amount of ferrous sulfate. Ferrous fumarate is the same, maybe even 200 and 325 or 1, whatever. And ferrous gluconate is the same. Citron, the have you come across citron, which is given for children, is a bit better. It's ferrous editate or ferrous. It contains about 27 milligrams of iron, so it's reasonable, but not 60. 60 because the 200 milligrams are 60 iron and ferrous sulfate is the rest of it. But it's too much, and that's why it causes gastrointestinal problems, and they won't take it. And even if they take it, they won't absorb more than what's needed. Right, combining iron and vitamin C, as we mentioned, we nearly finished there. Don't worry, you're not going to miss lunch. And I will allow enough time to IV iron is very helpful. I'm not against it. In fact, it saves our patient, young ladies, of transfusion and developing antibodies, anti-big C, anti-little e. You've heard of these things. It saves a lot of hassle in the future. And iron deficiency anemia is tolerated anemia. Patients usually are asymptomatic even when the hemoglobin down to 60. And rather than rushing and transfusing them, they need to be examined. The doctor needs to examine them and tell, no, I'm not going to follow a blind guideline of 70. He has to be transfused. That's not correct. There are patients that come to us or ask us in hematology, do I need to transfuse? The patient is well, is not in any compromise, not hemodynamically stable. I would give them iron. The hemoglobin will start rising with 10 grams per liter per week. So within 2 weeks, from 60, they will be 80. You don't need to transfuse them. You don't need to ruin their future with antibodies because they will have lots of problems with the possibility of hemolytic disease of the newborn. Okay, so that's in simple regular screening, as you already do, nutritional education and balance. I think I will stop here and allow for questions so that we would not miss lunch. Okay, any questions? Simple. Hematology is simple. Yeah. We try to persuade you. Well, the iron infusion works, and there is increase it by what I'm saying. It's expected to increase it by 10 grams. So it is from 80 to 90 to 100 per week. No. It actually stays in the body for almost 6 months. So it's stored. When you have 1 milligram or you absorb 1 milligram of iron every day in the normal function. So out of the 9 or 8 in your diet, you get about 1 to 2 milligrams, maybe 5 milligrams a day. When you give the 1 gram, which is 1,000, that is enough is equivalent to about what, 300 tablets or something like this. So it is almost enough for 6 months, unless the lady is having some active bleeding, piles or whatever. So we cannot rely on a dose. We need to measure it in at least 6 weeks, unless, yeah. So just to see whether the patient needs more or not. But it's not likely that they need more than 1 dose, which is the dose is calculated according to the body weight and the hemoglobin amount, or there is some recent rounding up of these figures, but it's calculated according to the body weight and the hemoglobin level. But it will rise up quickly within 2-3 weeks. If the patient is hemodynamically stable, don't rush for transfusion because it's not right. Okay.